Hi, my name is Thakur, and I am a musculoskeletal radiologist and director of sports imaging at UT Southwestern in Dallas, Texas. I will be giving you a brief introduction to interpretation of knee MRI. We will go over basic anatomic MRI interpretation by plane and a brief review of cases. So we'll go from anterior to posteriorly, starting with the coronal plane. These are fat sat images. On this first cut, you're seeing the patella en face, where you can assess for bipartite patella or patellar fractures. You can see the quadriceps and the patellar tendons and the medial retinacular attaching. Then we go more posteriorly, and you're seeing the MCL, which is nice, black, contiguous, the iliotibial band, the medial and lateral compartmental cartilage, the distal attachment site of the ACL and the proximal attachment site of the PCL, and the menisci, which are both the medial and lateral menisci, which are homogeneously black with sharp inner margins, as they should be. Because you're assessing all these critical structures on this plane, David Stoller, a radiologist who's considered the father of sports imaging, once called this the money plane. Going more posteriorly, you're seeing the medial meniscus, posterior horn and root. You're seeing the lateral meniscus body, again, the medial and lateral compartmental cartilage, PCL distally, the ACL, proximal attachment site. This is very important appearance because this whole lateral aspect of the knot should be covered by the origin of the ACL. And this can be really useful in the assessment of proximal ACL tears, as I'll show you in a case. And this is the proximal attachment site of a lateral collateral ligament. You don't see its distal attachment site in one cut. You only see a portion of it in one cut unless there's a tear of the ACL. So now you're seeing this normally oblique orientation of the LCL in one cut because this case happens to have an ACL tear. And I'll show you that in some subsequent cases as well. Going more posteriorly, this is a beautiful image of the posterior root of the menisci, both diving in here to the inner margins of the tibia. And you see this distal attachment site of the PCL, and you see the distal attachment site of the LCL and the proximal tibia-fibula joint. This is an example of a posterior root medial meniscal tear. As you can see here, it's not diving in, it's completely uncovered with fluid, compatible with a complete radial tear of the medial meniscus. Now we're going to go over the sagittal plane from medially to laterally. In this first cut medially, you're really able to see the medial compartmental cartilage and then the anterior and posterior horns of this medial meniscus, which are nice and sharp at the inner margins. Again, similarly here with the medial meniscus. And what you can also assess on these sagittal images is this meniscocapsular junction. As you can see here, there's no fluid or edema posterior to the medial meniscus posterior horn, and that's normal. And then on this sagittal image, you see this anterior root of the medial meniscus, which can have this normal draped appearance of the medial tibial plateau, and the posterior root of the medial meniscus, which can have a normal speckled appearance, not to be mistaken for a tear. You also happen to start to get the origin of the PCL, which is nice, dark, and contiguous. For comparison to this normal, you can see that this is what meniscocapsular separation looks like. There is fluid posterior to that medial meniscus with some edema and a medial meniscal tear, which we'll go over later. And this case shows a complete tear of that posterior root. Where that posterior root should be, you have an absence of the meniscus, which is called a ghost sign. And that's indicative of a radial root tear. Going more towards the knots on the sagittal imaging, you're seeing the entirety of the PCL, which is nice and contiguous and homogeneously dark, and the beginning of the ACL. And this cut really shows the ACL, the normal appearance of the ACL, which is striated in appearance and taut and dark. This is a normal appearance of an ACL. Here on this sagittal cut, you're able to really assess this patellofemoral articulation, the cartilage, the extensor mechanism with the patellar tendon, which is nice, contiguous, should be 6 to 7 millimeters in thickness. It's dark. This quadriceps tendon, this is a normal trilaminar appearance of the quadriceps tendon because it consists of the blending of the rectus femoris and the vastus intermedius and lateralis and medius tendons. Behind it is the retroquadriceps or suprapatellar fat pad, which is now the edematous in this case. And posterior to that is the prefemoral fat pad. Between these two fat pads is the suprapatellar recess or pouch, and this is where effusions accumulate. This is the prepatellar bursa, superficial infrapatellar bursa, deep infrapatellar bursa, infrapatellar fat pad or Hoffa's fat pad, and this is where you get scarring when there's been prior arthroscopy or edema superlaterally with patellofemoral maltracking cases. On this cut, you also start to get to see the posterior root of the lateral meniscus and the lateral aspect of the ACL. So here, going more laterally, you're seeing this anterior root of the lateral meniscus with this speckled appearance. That's not to be mistaken for a tear. That is normal due to the blending of the fibers of the ACL. Posterior root of the lateral meniscus is also well seen here. You're still getting the patellofemoral articulation. As you go more laterally, you're seeing the nice sharp inner margins of the lateral meniscus, the lateral compartmental cartilage also beautifully assessed here. The posterior capsule can also be assessed on this image, as well as this next cut. Proximal tibiofibular joint is also well evaluated in this next cut when you're getting into the body of that lateral meniscus. On this cut, you see the peripheral body of the lateral meniscus, again, the proximal fibular cartilage. This is showing the biceps femoris tendon inserting, and this is the oblique orientation of the lateral collateral ligament that we were discussing earlier, which goes from anterior to posterior. These are just a condensed version of the sagittal imaging in non-fat sat cuts, showing the medial, the normal, mildly concave appearance of the medial tibial articular surface, which has been likened to a golf tee, and the more convex contour of that lateral tibial plateau, which has been compared to a gun handle. So if you don't see the fibular head, you can determine the laterality by looking at the shape of this articular surface. This is just showing a normal appearance of the ACL on a non-fat side, which is nice and homogeneously dark. Now going with the axial cuts from superiorly to inferiorly. Here we're seeing the quadriceps tendon and the musculature, as well as the popliteal neurovascular bundle. As we go more distally, these two cuts in fat sat and non-fat sat really show the patellofemoral articulation beautifully. This is where you can assess for lateral patellar tilt, trochlear dysplasia, the medial and lateral patellar retinaculum, which are well seen here on this non-fat sat because of the contrast between the fat and the ligaments. You can assess the patellofemoral cartilage, as well as the musculature and popliteal neurovascular bundle posteriorly. As we go more distally, you can assess the popliteus tendon come in here, the origins of the cruciate ligaments, and this is more at the mid portion, but the cruciate ligaments here, with this being the ACL and PCL right here. You can also assess for Baker's cyst between the semimembranosus and medial gastrocnemius tendons, as well as the medial and lateral patellar retinacula, and this posterior capsule, which is also better outlined with the contrast here on this non-fat sat image. And this is just showing what a posterior capsular sprain would look like. It's completely frayed here as opposed to a normal posterior capsule. And as you go distally, you can see these are the pes anserian tendons, so you can assess for bursitis here. Distal patellar tendon attachment site, where you can measure the TTTG from, tibial tubercle trochlear loop distance, which is of significance in patellofemoral maltracking. And you can also sometimes assess for ganglionosis that happened here at the proximal tibiofibular joint. So to summarize what you're seeing best on each plane, I made this table. On the coronal plane, you're seeing the collateral ligaments the best, the MCL and the LCL. Then the ACL and the PCL, the menisci, especially the posterior roots, the cartilage medially and laterally, the proximal tibiofibular joint. And then the sagittal cuts are really great for that extensor mechanism, Hoffa's fat pad, ACL, PCL, tricompartmental cartilage, effusion, biceps femoris, and LCL insertion. And then the axial is great for the patellofemoral cartilage and the retinacula, effusion, Baker's cyst, and the popliteus tendon and that posterior capsule. So in this case, what do you think of the ACL? these are both fat sat images, sagittal and coronal, and you can see on this image, the ACL does not have that normal taut striated appearance. It looks like there's at least a partial tear here, right here, or even proximally, this is not a normal appearance of the ACL. Now on this coronal here, remember I had mentioned before that this whole lateral aspect of the knot should be covered by ACL fibers, and you can see right here the distal portion is not covered. But what I want to point out in this case is really the utility of the non-fat sat imaging. You can see that proximal half of the ACL is really virtually gone. Much better on this non-fat sat imaging because of the contrast between the fat and the ligament. So this is an example to show the importance of non-fat sat imaging and ligamentous integrity. Now we'll go over some other cases and facts. Case of a 19-year-old man who had sustained a pivot shift injury, and you can see that this ACL is completely disrupted from the proximally. It's undulating in contour and edematous. You can also appreciate that very well on the coronal imaging. The stump is right here, the origin is intact versus just distal to that, it's absent. You can also appreciate this bone contusions, kissing contusions of the lateral compartment that are classical with pivot shift injury, as well as in this case, this is the case I showed you earlier of meniscocapsular separation. So you see that again here with the concomitant posterior medial tibial bone bruise and this small vertical undersurface tear of that posterior bone. Now I'll go to the next case. In this case, this is a 47-year-old man who had sustained an injury, and you can see that this ACL is diffusely edematous, and you don't have that normal striated appearance. And right here, it looks like there's a high-grade tear. But this is a case, I think, in which the coronal plane really helps that how you're normally supposed to see this whole aspect of the lateral notch covered with ACL fibers. It's completely absent here. And you can see much better on this coronal that there's fluid signal intensity and there's a near complete tear. So the arthroscopy report was near complete tear, and I think it's because there were maybe some few intact residual fibers here laterally and distally. But with knowing that this should be covered really helps you in this case. This case also had a high-grade tear of the MCL, which is nearly completely avulsed from that proximal attachment site. It's edematous, and it had the patient also had this contusion in the lateral tibial plateau right here, as well as this proven on arthroscopy tear of the lateral meniscus posterior horn, where you have this peripheral longitudinal tear. Next case. This is a 47-year-old gentleman who sustained a valgus injury while skating. And you can see here how you don't have any normal appearance of the PCL. It's completely disrupted, full thickness tear at that mid portion. It's edematous and it's undulating in contour. This is how it looks in the non-fat sat, where you can see the disruption and the ligamentous fibers that are edematous. And what's interesting is this patient had a follow-up a few years later, and you can see what the normal appearance of the PCL looks like, because now it is healed. And finally, one last case. This is a 48-year-old man who had sustained an injury, and again, you can see this PCL is diffusely thickened. It should only be 6 to 7 millimeters in thickness. So it's thickened, and there's diffuse edema of that proximal portion with ill definition of the fiber. So there's a high-grade tear of this PCL. And what's nice is also in this patient, we have an internal control of what this PCL looked like about 10 years ago from an old MRI. And you can see how it looked completely black and contiguous, as a normal PCL should look like. And this is a high-grade sprain. Incidentally, the patient also has grade 4 patellochondral malacia with high-grade fissures and subchondral cysts. So that is my last case. Thank you for your time.